Firstly, we move on to the patient's personal details. Mrs. K is a 66-year-old Malay woman. She has been diagnosed with septic shock secondary to right thyroid mass with local infiltration TRO malignancy. She has hypertension for the past 2 years and currently taking the antihypertensive agent. She has CT neck and found out with right thyroid mass extending to paraglottic area, causing narrowing of the airway with possible esophageal infiltration. She was admitted firstly to the hospital due to the shortness of breath with noisy breathing. On her first visit to the hospital, she had her day 1 post-tracheostomy and she was on intravenous 3-pin half saline for 24 hours. She has no episode of desaturation on the tracheoventi mask and she was referred to a dietitian for her enteral feeding.
So, for social background, the only data provided was her socioeconomic status, where Mrs. K is chef at school canteen. And for the diagnosis, Mrs. K was diagnosed with septic shock secondary to right thyroid mass with local infiltration TRO malignancy. She was admitted to the emergency department to the shortness of breath associated with noisy breathing. CT scan had reported the presence of thyroid mass extending to the paraglottic area and causing narrowing of the airway with possible esophageal infiltration. In this case study, thyroid cancer can be caused by mutation or genetic alteration in thyroid cell, which allow rapid growth of cell in the body, and the tumor form will lead to the invasion of nearby tissue and spread to the other parts of the body. Where septic shock can be caused by the viral, fungal, microbacterial, protozoal microorganism, and commonly caused by the gram-negative aerobes bacteria, such as E. coli, Klebsiella species, and Pseudomonas aeruginosa.
Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Hassan Zamintul Sulaiman. So I will briefly explain the medications. So for Mrs. K, 2 insulin have been prescribed, which are subcutaneous insulin atrapid and insulin isolatide. Both of these insulin are used to treat her diabetes mellitus. One of the side effects of insulin atrapid are hypoglycemia, injection site reaction, and edema. Meanwhile, for insulin isolatide, also hypoglycemia, swollen joints, diabetic retinopathy. So for insulin atrapid, it was advised for, in terms of this case, Mrs. K to administer with enteral nutrition within 30 minutes of injection. Next is intravenous rocephin, which is used to treat bacterial infection, and the side effects are rash, bloody or watery stool, and nausea. And there might be food-drug interaction with containing calcium where it could impair the drug absorption. So Mrs. K also has been prescribed with intravenous noradrenaline to treat the hypotensive due to septic shock, and the side effects are anxiety, headache, and tremor. Next is intravenous pantoprazole, which is to treat the esophagus due to the damage of gastroesophageal reflux disease. So the side effects are headache, diarrhea, and redness. Mrs. K also has been prescribed with double hematinic to treat anemia and prevent low blood level of ions. And the side effects are constipation, diarrhea, and stomach cramp. Lastly is paracetamol, which is to treat fever and mild to moderate pain. The side effects are nausea, vomiting, and constipation. It is recommended for this patient to avoid crab food, take double hematinic, and avoid drinking any caffeine before consuming paracetamol. So next we will go to chapter 5. The first one is assessment of anthropometry. The weight of Mrs. K is 70 kg and her height is 150 cm. Her BMI is 31.1 kg per meter square, which is categorized as obese class 1. Her ideal body weight is 50.6 kg and ideal weight range from 41.6 to 56 kg. For biochemical data, so for renal profile, only potassium is normal. Her sodium, creatinine, and chloride are high. Meanwhile, for her albumin level is low and her CRP are high. Okay, for the blood count, her hemoglobin and red blood cell are low and her white blood cell is considered as high.
Assalamualaikum, I am Soira. So I will proceed for the clinical part. For the patient, pressure is a bit high. For the less than 8, which is severe injury, and his blood glucose a bit high because For the signs and symptoms, the patient experienced shortness of breath with noisy breathing and currently diagnosed with septic shock secondary to the right thyroid mass with local infiltration (TRO) malignancy, having right thyroid mass that extend to periglottic area, underlying with hypertension, having on IV 3-point saline for 24 hours. Estimating the energy requirement for the patient using Harris-Benedict equation and quick method. For the Harris-Benedict equation, using the stress factor 2.0 due to cancer and activity factor 1.0 due to sedentary, energy recalculated was 2,586 kcal per day. 25 kcal per kg body weight is used to estimate the energy requirement for the patient. Using quick method, 1,750 kcal per day is calculated. The recommended energy is 2,000 kcal per day. For the macronutrient distribution, a large percentage, 50% will comes from carbohydrate, 21% will comes from protein, while 29% come from fat. Having episode of shortness of the breath, so cannot taking the oral food, enteral route will be designed for the patient, sure that the patient get the optimum energy to reduce the risk of complication related to surgery. For the enteral feeding, the standard formula using enteral product in a Plus was chosen. A Plus in one scoop provide 60 kcal energy with 8.2 gram of carbo, 2.4 gram of protein, while 1.9 gram of fat. The patient will eat for 6 times per day. Feeding regimes involve 4 steps using standard formula for the 6 times of eating. From the slower scope, because the need of to check the tolerance for the patient, either he can accept the enteral product or cannot. 1 will provide 120 kcal. For the step 2 will provide 240 kcal. For the step 3 will provide 480 kcal. Step 4, 2160 kcal.
So these are the macronutrient distribution table for weekday. And weekend, once Mrs. K condition is getting better, she will have partial enteral feeding, and we will gradually introduce to the oral foods. So here is the menu planning for enteral nutrition with a liquid diet. Next, we have a menu planning that only include soft diet. And lastly, menu planning that only include fully solid food.
For the short-term goal is to ensure that adequate enteral nutrition infusion for the patient, as yearly feeding need to be initiated to reduce the further complication related to surgery. Second, to ensure adequate protein intake. Amount of energy and protein is significantly will reduce the risk of complication. Normal patient which is below BMI 25 kg per meter square. So for the long-term goals, one is to prevent the macronutrient and micronutrients deficiency. Restriction of the food intake will significantly cause calorie deficits that will increase complication of the nutrient-related disease such as malnutrition. And for the second, in the long-term goals, is to preserve the lean body mass. The malnutrition can cause the loss of the muscle strength. Patient is intervened with enteral feeding, need to monitor the patient tolerance to the enteral product that being provided by flushing the tube pre and post feeding with 20 cc of water. Within the 24 hours, check any symptoms of intolerance, having abdominal distension. Second monitoring, monitor clinical data by assess the renal profile value to ensure within the normal range. The sign and symptoms of refeeding syndrome RFS with the presence of the fluid accumulation, electrolyte imbalance, and hyperglycemia.
Hi, my name is Fatina Afka and I'll be there for the discussion part. Sepsis can be defined as the infection with evidence of systemic inflammation. The prevalence of sepsis cases has increased from 50 to 65 cases per 100,000, and this trend has been increasing by 9% of each year. Moreover, from the 2% of the hospital admission prior to this disease, approximately 9% of the sepsis patients progress to severe sepsis, and 3% of the patients with severe sepsis were experienced with septic shock, according to N 2005. Septic shock is a term used to indicate the most severe form of sepsis that are characterized with persistent arterial hypertension, and despite adequate volume resuscitation. Persistent arterial hypertension can be defined as systolic arterial pressure below than 90 mmHg, a mean arterial pressure less than 60 mmHg, or reduction in systemic blood pressure of more than 40 mmHg from baseline. Septic shock is the most common cause of death in intensive care units, and it is the 13th most common cause of death in the United States. Severe sepsis and septic shock have mortality rates of 25% to 30% and 40% to 70% respectively. Thyroid gland is the part of the endocrine system that secretes various hormones into the bloodstreams. It is the butterfly-shaped organ which is located on the front of the neck and under the larynx. Thyroid cancer has long been thought to be caused by a multi-step carcinogenesis process in which cancer cells are derived from thyroid follicle cells through multiple incidents of genome damage, particularly in oncogenesis or anti-oncogenesis that speed up proliferations or foster maintenance phenotypes like the ability to invade surrounding tissue or metastasize to distant organs. The progression of thyroid cancer is a process of accumulations of genetics and epigenetics alteration with corresponding progression, derangements of signaling of phase. It has been observed that several diseases such as sepsis is frequently accompanied with the changes in hormone levels or function, such as thyroid hormone, insulin, and adrenal glucocorticoids. The alterations of thyroid hormones refers to low T3 syndromes that have been linked to sepsis mortality, according to Wu et al. In 2017.
The right thyroid mass extending to the paraglottic area has caused narrowing of airway of Mrs. K. This led Mrs. K to experience shortness of breath. Because of that, she needed to undergo tracheostomy. A high-protein diet is needed to promote wound healing for the post-operative care. The tracheostomy causes Mrs. K to have swallowing difficulty, and then enteral feeding should be started. The septic shock and malignancy conditions causes increased energy and protein need of Mrs. K. Mrs. K need energy requirement of 2000 kilocalorie per day, while the protein requirement is 105 gram per day or 1.5 gram per kilogram body weight per day. This is to prevent lean body mass wasting, weakness, and infections to improve recovery. The discharge plan can be proceeded after Mrs. K has reached adequate energy and protein intake. After discharge, increasing protein, which range from 1.5 to 2 gram per kg per day, and calories is needed to attenuate lean body mass loss and promote early mobility and recovery. Then, Mrs. K should be provided high-protein oral nutrition supplements for 3 months to 1 year after discharge. The kilocalorie goal may be 4,000 to 5,000 kilocalorie per day based on Minnesota starvation study.
In conclusion, sepsis is one of the causes for septic shock, and the prevalence of the sepsis has been increased each year. Septic shock is the most common cause of death in the intensive care unit, and people with weak immune system are more at risk of getting the septic shock. The septic shock can be treated with healthy and balanced diet, with enteral feeding and high protein intake. The enteral feeding can restore the gut function of the patient. Meanwhile, the high protein intake is associated with the hypermetabolic condition of the patient, which are septic shock, cancer, and post-surgery condition for this case. To avoid recurrence of the disease, a critically ill patient's nutritional status must be managed accordingly to the patient's laboratory data results. That's all from us. Thank you.